Happy Wednesday and welcome back to blackdoctor.org, where wellness and culture connect. I am Dr. Cordai Decoto, board certified podiatrist and podiatrist for Neighborhood Health, a federally qualified health center in New Jersey, providing care for all, regardless of status or insurance. I am also the co founder of Sisters in Podiatry, a Facebook group that focuses on Black women in podiatry within the United States and the Caribbean, and your host with the most for our favorite show, Stepping Forward with Dr. D, your gateway to all things podiatry. So I created this monthly platform for the community and for those who support us to have a comfortable space to listen, learn, and be heard. So grab your favorite beverage and get ready and let us know where you're coming from. Brooklyn, if you're coming from LA, if you're coming from Chicago, if you're coming from Louisiana, we want to hear it all. Shout us out in the comment section. So it is my pleasure to introduce our guest for tonight. First guest, I'm proud to call a friend and a colleague, Dr. Marnell Moore.
Hello.
Welcome, Dr. Moore. Dr. Moore earned her undergraduate degree in chemistry from the College of St. Elizabeth in Morristown, New Jersey. She then served a 4-year term as a medical technician in the United States Air Force. She's a bad chick. She got her medical degree from our alma mater, the New York College of Pediatric Medicine, and did her graduate work residency at Wyckoff Heights, Brooklyn, New York, where she specializes in forefoot and rearfoot podiatric and diabetic foot care. She is board certified with a fellow of the American College of Foot and Ankle Surgery. She is fluent in Haitian Creole, so ça passe, in French and conversational Spanish. Welcome, Dr. Moore.
Thank you for inviting me.
And obviously, you're my girl. And I'm also so pleased to welcome our next guest, Dr. Demetria Pennington. Welcome, Dr. Pennington.
Thank you.
Dr. Pennington is a dedicated and compassionate pediatrician for 25 years, even though she looks fabulous. You would never guess that. Providing excellent care and service to patients from birth to 18 years of age. She is board certified in pediatrics. She did her undergrad at Cornell University and also medical school at Cornell University Medical College. She did her postgraduate training at the Hasbro Children's Hospital, Brown University. She is our assistant CMO for Neighborhood Health in New Jersey, which does all the daily operations and clinical functions and development of medical policies, protocols, and procedures in accordance with evidence-based practice guidelines, and is a clinical lead for the pediatric department. And they're both my friends, so welcome to the show.
Thank you again. Thank you.
So I know, Demetria, you have been slammed. Boop, boop. Everybody's going back to school, which means parents, shame on you. I know what you've done. You waited to the last minute to get those physicals. You needed a form. Who didn't get a vaccine? And you've been driving pediatrics to drink. Okay. I think peds need education right now. This is the time they should be taking it because they've been working left and right. And so, Dr. Pennington, I know that you refer out to tons of specialties. And one of the beauties of working together is you refer to moi.
Yes.
Tell me, I know that I get some of your referrals from the colleagues of the pediatric department. What are the things that parents come to you and complain about when they're like, look at my child's foot or leg? What are you seeing?
So we have a lot of parents coming complaining about how the child is walking, whether it be they're walking on their tippy toes, if their feet are turning in, which is what we would call pigeon-toed, or turning out, less common, more so turning in, flat feet also. Look at their toes. Does this look like a fungus? Is this an ingrown toenail? That doesn't look quite right. And then also some kids more in the age of like elementary to middle school when they're playing sports or more activities, a lot of heel pain, shin pain, ankle pain, like that.
So Dr. Moore, you heard all that. You and I are not. Mm-hmm. So let's break some of that stuff down. So let's talk about, I think, the most common one. Let's start with flat feet, and then we'll go to pigeon toes, the ingrown toenails, and then our sports kids. Because a lot of kids are getting into football, basketball, running, cheerleading. I was a cheerleader. Let's talk about Let's start first with what is flat foot? Because every parent swears, and even adults swear they have a flat foot. Tell us a little bit about that in layman's terms for our audience.
Well, I always tell my patient flat feet mean that the whole bottom of your feet is touching the ground or the shoes. There's no arch. There's not even a little hump going down. And some people mistake because when they sit and they have an arch, I say if you sit, you have an arch, but look what happened when you stand up. If you don't have an arch, you still have a flat foot. That part is called flexible flat foot. That you could, but when you're standing on your weight and your foot is flat, you're flat foot. Very simple.
Great. What kind of things, Dr. Moore, do you, and I'll talk about what I offer for our flat foot kids?
Well, I tell two things. If it doesn't hurt, don't bother it. If you don't have pain, do not bother it. Some people have flexible flat foot, especially after they reach 10 years old. But if I tell parent, if they come after 7, they want to fix the flat foot, is a problem. You cannot fix it but surgery after 7, 8 years because they reach skeletal maturity. But if they having pain, they feel tired sometime when they walk, they don't want to stand up a lot or they're always complaining, then the most simple thing is orthotics. Or a layman term, put an insert inside your shoes. Either they're custom or over the counter. This where you can just based on your shoe size, we could get it.
Fantastic. I'm going to add to this and let us know where you're coming from. We want to see where everybody's from and give you guys your shout outs. So yes, Dr. Pennington, when you send me those flat-footed patients, I agree. The younger they are, the easier it is to manipulate because the bones have not reached adult bones, meaning that they're still growing. So if we notice it, I'm an orthotic girl. Let's put the foot in the right position to allow the feet for them to walk well, and to my favorite thing, walk strong. X-rays to see if there's any abnormalities. Sometimes patients will have flat feet for a variety of reasons. Sometimes they'll have flat feet because they can have what's called a coalition, where sometimes they have, when they're younger, cartilage, just like you would have like on a chicken bone, that cartilage, that rough stuff. Sometimes it can be a problem where it jams between certain joints and causes the foot to go out. Sometimes as they become more mature, 11, 12, they can have a bony bridge that's keeping the bones in an improper position. Patients like that usually need surgical intervention, which we do. But if we can get them early and they're flexible, like Dr. Moore mentioned, then we definitely can put them in orthotic. And I see people are saying hi to us. Yes, we see Jashida from Panama. Buenos dias. We see one of our former teachers, professors, Dr. Denise Pratt Sampson, watching from Long Island.
Oh, wow.
Say hi to you, Dr. Sampson, with lots of love. She was a fantastic professor at the New York College of Pediatric Medicine. So thank you.
And one thing I want to say about flat foot, most pediatrician, when patient, unfortunately, the one that needs surgery, they usually come too late, and a lot of pediatricians say, oh, your child is gonna go out of it. And I always tell them, yes, but there's 25% that doesn't. So why don't you just send them? Orthotic is not gonna hurt. Even the moment actually they turn 2 years old, they should be, you should treat them so that we could make sure that they can go out of them. But you don't know which one is gonna go out of them and not. So it's better to treat it young, and then they come at 10 or 12, and then now the parent upset because a lot of times say, I'm sorry, they're not gonna go out of it, and your son or daughter are gonna need surgery.
I agree. And Dr. Pennington, sometimes we see, kids like, I think that every child personally should have a podiatric evaluation. You see so much and you guys send it to us, but sometimes there's pediatricians that are just not well versed with things in the lower extremity, where we'll pick up something quicker than you will. So if the parent has anything that they're like, I say, send them out to us. It's better for us to, I always say they cry with you. Most times they are laughing with us. Our pediatrician, and I always tease her because I go over to the peds side because of the, vaccines. I make them come to me and I'm like, hi, Pudding. And they're giving me the eye like, who's this chick? And then I make them walk. And they're like, really? I said, go ahead, walk with mommy. And then I let them run. And then they're looking at me like, nah, I got to check with mom because I don't trust you. And their mom will let them run. They come in and they're excited. And then we'll do the evaluation. I'll let them draw in my hands as I draw in their knees as we're checking them. And I let them look at the bones in the foot. And I get, bye, doctor. And I'm like, see the difference? I said, that pediatrician, bad, bad, bad. So
Yep.
Necessary.
Exactly. Necessary. So one of the other things that Dr. Pennington, you were saying that you see, tell us about some of these bad ingrown toenails, because some of these things, especially your teenagers, I'm like, good God, what has going on in that foot? What happened?
Well, part of the problem is when they get to be the teenage age, parents aren't taking care of them. They're doing everything themselves, and they usually wait until they can't walk on it. It's like really, really painful. And I always tell the kids, you're taking care of yourself. If you have a problem, you need to tell mom or dad, so mom or dad can let us know so we could, take care of it. Unfortunately, it's kind of gotten to the point where it's like, you need to go to the podiatrist right away. How long has it been? And I'll have like a long time.
Exactly. I'm going to say I've got some more shout outs to give. We see Robin Wilkes viewing from St. Louis, Missouri. Welcome. And one of my favorite people, Michelle Reynolds West from Jersey. We see you. Thank you so much. So Dr. Marnell, when we see, I'll talk about the kid. You talk about kids. I'll talk about teenagers. Teenagers, I want to do this because the parent looks aggravated at
yes.
And one of the things I always ask, how long have you had it? If a child has had an ingrown toenail over a month, they automatically are getting an x-ray. And a lot of people are like, an x-ray for a teen? Yes, because there's not much fat in the toe. And those types of infections can sometimes go into the bone, which is called osteomyelitis. And I've had a significant amount of children that come in and have and the parents look at me and I'm like, this is not an in-office case anymore. This is now a hospital-based case where we have to go in, put the child on antibiotics. Usually it's an IV, and go in there and clean it up surgically because it's that bad. And then we consult with our other colleagues like infectious disease. What type of antibiotic does this child need based on the cultures or swabs that we take of the wound and the bone, and for how long? And that's traumatic. No child wants to do that, let alone the parents taking off time for that. So some of our younger kids where they're still, being looked at more by their parents, what do you say and what type of treatment do you give them, Marnell?
Oh my, to tell you the truth, over the past 20 years, I have to tell you, I have a total of 5 cases of practically kids below 5-month olds. And actually, personally, one of my second son, since he was 3 months old, he was having ingrown. And for me, it's traumatic to me and traumatic to the child because and it wasn't a one-time ingrown toenail. It's a recurrent. And we do something called slant back where you try to go and remove it because I didn't want to give them a needle. And then when they keep recurring, you don't want to permanently remove it. And I would tell parents, I don't want that. They're so young. I don't want to put phenol or chemical, but I have a couple of that. And I just like soak it, betadine, and show the parent how to trim the toenail. I do not agree in trimming the toenail straight because the nail will keep going. You have to trim it in an angle to prevent it from reoccurring. But that's what I do, young kid. And I had 5 kids that they had it all the toenails. And they were about 10. And I had to take them to the OR. And I was like, oh my gosh, I have to remove permit. I didn't want to touch them in the office. So I think I permanently removed the corners on the big toes, but the small toe was so small, like what to remove.
Don't do that.
I didn't do that permanently. I told the parent, I cleaned them up and stuff. But yeah, I have a lot of interesting cases. Who just like 2 of them were siblings.
So with children, if they're under the age of 2, I do what's called a slant back, like she said.
Yep.
I'll try to trim it and give the parent a minute. Once they hit over 3 and it's recurrent, obviously we're going to do a nail avulsion. A nail avulsion means that we inject, I'll use my finger, my bad nail polish. We inject the toe to put it to sleep. and then we'll cut out the nail. The nail actually doesn't stop where you think it does. People think, I don't know if I did that right. People think that it stops here. It actually stops down here. So that's why we're anesthetizing or putting the toe to sleep so there's no pain to clean it out. If a child is having recurrent nails and they're over the age of 12, then we start thinking more permanent procedures sometimes, as we put, which Dr. Moore mentioned, a chemical called phenol, which gives you a very high percentage of not getting an ingrown toenail again. But if they're in that osteomyelitis category, which is a lot of times teenagers and young adults who are not, they don't understand how to take care of their feet, and it shows on an x-ray that it's an osteo, or the radiologist is requiring us to do an MRI, then unfortunately we're going to the operating room, which neither one of us like to do. And the poor pediatrician is looking at us like, what happened? And I'm like, Dr. P, this patient has osteo. And the beauty of working together, obviously, in a multidisciplinary group, I can walk right over to her.
Immediate follow-up.
Starburst from you, right? My favorite thing is the pink Starburst, because I'm an AKA all day, and I like Starburst. So it's nice to have that interdisciplinary approach. And I want to say hello, more folks. I love it. Benea Smith from Phoenix, Arizona. Hey. My dear friends from the Black Breast Cancer Alliance, Ricky Fairley, CMO, and my sorority sister, Dr. Monique Gary. We say hello. Executive Director Haley Brown, we say hello. And Joy Hunt Briggs, good evening from Barbados. All right. I'm a West Indian all day, Trinity and Grenadian. We love our West Indian people. Thank you for watching. So, I'm so sorry.
That, the procedure that's Kodai was talking about, we do all that, the nail aversion in the office.
Yeah.
And I do also get some adult who refuse. They saw the needle, they faint. I had few adult that demand to go to the OR, and I'm like, that's a lot of money, paying hospital bill, anesthesia.
And sometimes the insurance won't cover it. Sometimes what's their problem?
They refuse. I had taken about several adults to the OR. They refuse, and it keep reoccurring, and then infected. They refuse if they're scared of needles. But that's a very expensive procedure. Then when you take it to the OR, where you could do it in the office, you cut off a hospital bill and an anesthesia bill.
Exactly. One of the nice things too, let's talk about, we had a recent patient, our autistic kids, and there are autistic kids that are nonverbal. Those types of children, absolutely, we would take your child to the OR.
Yes.
We can't predict how they're going to respond. I mean, sometimes they're moving and kicking. Kids in general are doing that. But autistic kids is a higher percentage. We have to, reduce our risk of being stuck with a needle. So it's much easier. I did that recently with one of the patients from Dr. Pennington, and it was very successful. And he had it on both. A lot of times kids, if they're rolling in, which is called pronating, or they're heavier in stature, will get those chronic ingrown toenails. And so he's a happy camper, and the parent is happy, and it was, non-traumatic per se, than to do it in the office where, why struggle and why put the parent or the child through that.
Right.
So Dr. Pennington, so we talked about ingrown toenails, we talked about our flat feet. Let's talk about our pigeon toes. I swear that people love that word, pigeon toe. My child is pigeon toe. I'm like, is a pigeon really walking? I want to go watch a pigeon now. The pigeon is walking in like that. I guess they are. I mean, my folks who are in Manhattan, the city, tell me if you see a pigeon walking pigeon-toed. I want to know. So I'm sure you get that. Tell us what you see and why you send them to us.
It's usually when the child is 9 months, 12 months first starting to walk is when the parent will start to notice it. I try to tell the parents when they first start walking, their gait is a little bit unsteady. So it's not necessarily that it's going to stay like that forever. And I'm a big proponent. Usually the body does what it's supposed to do. Let's just kind of watch it for a little bit and see if it's, getting either worse or not getting better. Baby is just falling more than the average baby would fall, or toddler, I should say, is when I would, send to you and go, there you go. Tag, you're it.
Tag, I'm it. So Dr. Moore, let's break down that term pigeon toe, because I can't stand it, but I know what it means.
Everybody knows what that means.
Exactly. Tell us what that means when the parent comes in, mom, dad, grandparent, auntie, cousin, whoever. What does that mean?
Particularly the walking with the toe in facing each other. It's like
Yeah,
this.
turned in.
Yeah,
Yeah.
turn then. And it's a combination of a lot of stuff, but I evaluate them. A lot of time is coming actually not even from the foot, it's from the hip and for the knee. And I always send them to see a pediatric orthopedic because you have to make sure. I tell my patient, look, you called it, you make sure it's a pediatric orthopedic. You don't want to see an orthopedic. They're used to seeing the big bone, the hip, the knee, and they only see 5-10 of kids a year. You want to make sure you see a pediatric orthopedic. And what Dr. Pennington said is always good, I think. Don't wait until you watch. Checks, have them send at least a podiatrist or pediatric orthopedic because a lot of time, you, especially when they're young, you could even put like a twister cable or there's so many things you could do that could correct it. Actually, in our world, the moment if we could find out the moment they come out of the wound, we put a brace on, we put a shoe on, it will correct them because it's true, because they're flexible. You could manipulate the bone, but when they start getting older, it is hard to manipulate. And by the
Absolutely.
time you're watching it, and if you don't say, and then we already lose a lot of time. And then simple orthotic can fix that. And also, once in a while, I always ask about the development. How was the pregnancy? Was it a normal birth? And if there was the first child, and because once in a while there could be sign of neurological problem also. And so then I will also,
Get into our tippy toe walkers in a little bit.
yep, especially, and I'll send them to see a neurologist to make sure everything else is okay.
So I'll take that over. A lot of times when we see your child, and before I say that, we want to give a shout out to Rashanta Parker Holcomb. I think I'm saying that right, from Lafayette, Indiana. Hi. Um, there are the three conditions we see from the foot. You can be metatarsus adductus. You'll hear that term.
Mhm.
From the knee, we call it internal tibial torsion, and from the hip, it can be anything from hip dysplasia, so on and so forth. So I evaluate if it's from the knee or the foot. A lot of times, if they're under the age of, say, one, they're not walking. 1, 2, we use Dennis Brown bars. We use reverse. When they start walking, we might even do reverse lash shoes. We encourage younger kids who are sitting not to sit in, what is it? We tell them not to sit in
W.
crisscross, not in a reverse W, but to sit in crisscross applesauce.
Yes.
And I usually make the kids demonstrate it. They love showing me they can do it because that causes unnatural pressure on the hips. So when they're sitting on their knees, splayed out with their feet, do not let them do that. Crisscross applesauce when they're sitting in that, that's much less pressure on the joint. And orthotics as well if they're at a certain age. But like Dr. Moore said, once your child starts getting at a certain age and they're walking in like that, a lot of times as they get older, they'll start tripping because they're moving faster. And that requires an orthotic or something called an AFO, which may be even a little higher than an insert into the shoe. And sometimes, it's a pain in the neck because your parents are like, I got to find that shoe for it to fit. They're like, yes, suck it up, buttercup, because we need that kid to have that control. I tell my parents, bring the inserts with you when you shop. That is the best way to know if it fits because that kid has to wear this when they're doing the majority of their activities. And even sometimes, some of my kids, depending, I even recommend physical therapy if they're
That's
at a
what I was
certain
going to say.
age,
Yep.
right? And we're like,
Yep.
the therapist will help massage out and move a lot of the soft tissue and bone to a that's maybe be tight, that position of the foot, bone, or knee, into a better position as well. So those are the things that we see with your tippy toer. I mean, with our intoers.
Of
And I
course.
want to talk about your tippy toers. So Dr. Pennington, once again, you have those cute little kids who are like, "Pop, pop, 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 pop," and it's
Mhm.
adorable. But then some of them will you see will stand still in tippy toe way, which you're like, wait a minute. Some of them will go flat, and then they start walking again. You see the pop, 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 pop.
Mhm.
So tell us, Dr. Pennington, what do you see in your those kind of kids, and why do you send them to us?
So usually, again, it's one of those things that some kids do walk on their tippy toes when they first start walking. But like Dr. Moore said, part of the evaluation are there other factors to make me decide is this something benign, which means it's going to resolve itself, or problem. If there was problem, you know, problem cerebral palsy or other things like that. That could be a neurological problem, short Achilles tendon. I'm sorry, I'm getting into you guys' area,
That's
but
all
just
right.
doing
We're a collabo. It's a collaboration.
yes,
Don't the rappers do that? Why we can't do
a
that?
collabo. Yeah.
Look.
So yes, so definitely birth history, any past medical history, anything like that will kind of help me decide. And other developmental too. Do they have any other areas where they're developmentally delayed, which will help me kind of decide, okay, this is probably not going to resolve on its own. I need to, refer to get you guys
What are
involved.
the developmental milestones that you're looking for? And parents, you really should listen to this because sometimes you may see this just hearing it to go, something's not right. What are the things that you see, Dr. Pennington?
So things, well, so they're motor, gross motor, which is kind of like the walking, like the more major things. You have fine motor, which will involve more with your hands, picking up things, being able to, feed yourself with a spoon, depending on what age you are. There's also their verbal skills. Are they saying words at the time that they're supposed to? How many words they're saying? Are the words that they're saying clear? Those are the kind of other developmental areas we look at in addition to motor to kind of see, is this a globally developmentally delayed child, or is it just, one area of delay?
So, Dr. Moore, let's talk about our tippy toers. Tell me what you when now you've been referred to by pediatrics. Parent comes in and the child. Let's start with part one. My child tippy toes, but when they stop walking, they stand flat. Tell us what that means to you.
For me, probably be just like a bad habit or comfortability. For me, it doesn't mean they have, usually more likely they don't. So what I would, like you said earlier, physical therapy, that's one of the big thing I like to do, and also orthotics to
Mhm.
have them. I'll send them to, usually even sometimes they need, like we call them AFO. This is all the way to the leg, and then to force them to go down, before we even consider surgical if it is the Achilles tendon that's too tight.
And and if it's too tight, when do you decide? I guess the question is, when do you decide that a surgery needs to be done on this child?
After 3 to 4 month conservative treatment, physical, especially intense physical therapy is not working, then I'm like, now we consider to do, surgery. And some surgeries are very simple. The recovery, like, gastric lengthening. When you go high up the leg, you lengthen the gastric. The Achilles tendon, now you can do them. It's minimal invasive, which is also good, but usually at least 4 months of intense physical therapy and orthotics. But unfortunately, parents had to follow too. A lot of parents will disappear and come back a year later, and you causing more problem to the child. You have to follow through. You have to.
This is good conversation. Let us know where you're coming from, guys.
Mhm.
We'd like to hear all about it. Let us know if it's your first day of school for your child, if it's today. A lot of people across the country have already started. The Northeast is poor traffic on everybody. It's
Yes.
starting as of today and definitely tomorrow. New York
Tomorrow.
City
Mm-hmm.
schools and
Oh
things
my
like
gosh,
that.
yeah, it's
Give us
work.
a shout out and tell us how your first day was with your child, grandchild. My niece and nephew got their TT to sucker them, and they got gifts each, which I love because I love to see kids
Wow.
go back to. Well, they're
Really?
my babies. I love to see the kids go back to school. So I'm going to chime in on that. I like to see. I evaluate children. I also want to see, as you said, is it neurological? If it's neurological, I can tell. Usually, it's the
Yeah.
milestones are missing. And number two, I also see if they're standing still. When they're standing, are they standing in on tippy toes or not? If they're standing on their tippy toes, automatically, then that's not going to resolve itself. So now we're looking to see, is it neurological or is it tendinous? If it's tendinous and the child has met all their milestones, they may probably need surgery, which, as Dr. Moore said, they're percutaneous or making little nicks in the skin and lengthening the tendon with a stitch. It's super simple. And other types of procedures that we've used on a child. If it's spastic, we'll evaluate them. So I said, foot does this, and
Mhm.
or we see that their milestones that they should be meeting don't really they haven't
They're
met them.
delayed.
Then
Mm-hmm.
automatically delayed. Thank you. Automatically we send them to pediatric neurology because surgically that may not be the best thing to do because it's a neurological issue going on. And usually the pediatric neurologist will make decisions at that point. Is it something that surgically could be corrected based on their evaluation or not? So those are the things I would tell everybody to, know your milestones, discuss them with your pediatrician, check to see. Some kids meet them earlier and that's okay. Some people meet them later and that's okay. But if they're delayed, then that's something that you shouldn't put your head in the sand. Let's address it. There's so many great treatments these days to make sure that our kids, do well.
Right. At every visit, the pediatrician should be checking the milestones for the age of your child and saying they should be doing these things. And then coming up, they should soon be doing these things. So between this visit and the next visit, you kind of have an idea of what to look out for.
Exactly. So let's go into, we've talked about flat feet, we've talked about pigeon toes, we've talked about tippy toeing, we've talked about a bunch of stuff. Sports. Okay, I know I have friends who are like, Lord, their child plays volleyball, the kid, basketball, soccer, swim, whatever the case may be. And a lot of times those are the parents that are coming in like, oh my gosh, especially if it's a contact sport, jumping sport, things of that nature. We get a variety of things. Dr. Pennington, I know the things that I see. Tell me what your kids who play sports, and usually that's, I would say late grade school into high school. What are you seeing that these kids are complaining about and or the parents?
Well, for your realm, a lot of ankle pain and a lot of heel pain. Sometimes pain in the shin, but a lot of ankle. I see a lot of that.
And Dr. Moore, what do you when these peds are throwing them to you and they're complaining about? Let's start with the shin. What is that in layman's terms and medical terms, and what do you tell parents to do?
Well, shin splint. Well, a lot of time, number one is not enough stretching.
Mm-hmm.
Not enough stretching with those kids. This is what I tell my parent when it comes to sport. Those kids, they are now performing at a level of professional because you see how they are in sport, because they already now middle school to high school, they're working hard. And now I hear parents are making kids do a year later so that they could become the next Jordan or the next LeBron or whatever it is. So they are performing at a level, believe it or not, I feel they're performing at a professional level, but they are not getting the professional level care. And parents look at me, what? I say, LeBron have a personal trainer, isn't it?
Hello.
You know, I say if those kids should have a personal trainer, or they should be coming to us, and then we're sending them to physical therapy, especially during the season and also a little bit off season. Those coaches, those kids are not stretching as much before and after. They're not. They are putting into the fire, and that's why they're hurt. And I tell the parent that I say, if you want your kid to perform better, you have to keep coming the moment they have pain, and you have to have them to come physical therapy, since you can afford to give them a personal trainer. So they need to stretch. That's number one thing.
I will definitely say that because Dr. Pennington, you know that I have been big about that for school districts. And I think that stretching, a lot of times when I see kids, I said, show me what you do to stretch before. Always stretch a little bit. Show me what you do to stretch. A lot of times it's inadequate. And so that is that. And then they're taking the hits and the stretching, what have you, the injuries and the overuse, especially if they're playing at a high level, like they're competitive.
Always high level.
And, those are the kids that usually are sustaining more of the shin splints. I was a cheerleader and I remember I got them and I was like, oh, what is this? I'm 16, 17. No way. And, you think you're bad at that point. But I remember our cheerleading coach was big about his stretching and yoga. And I was like, oh boy. And so, yeah, that helps quite a bit. Switching into another part of the body, let's talk about heel pain. Heel pain happens on adults. That's one of the biggest things that we see.
Mm-hmm.
And Dr. Moore, I'll switch to you. Kid comes in, Dr. Pennington's like, "Ooh, this kid has pain in the heel." Kid, and what do you do? What are some of the techniques and your diagnoses that you see on these kids with heel pain?
Definitely X-ray. X-ray,
Absolutely.
because 9 out of 10 is because they Achilles tendon and also either inflaming the growth plate, because that's what I told parent also. I say your kid, I like to show them X-ray. You see, I see it's not a fracture of your calcaneus, it's your
Heel
growth.
bone, because you said
Yeah, heel
calcaneus,
bone,
big
yeah,
word.
heel bone, yeah, or your leg bone, because I show them all the
Mhm.
growth plate. But number one is because overuse
The
Achilles
constant,
tendon, and
yeah.
then also now sometime you have to do, even if it is the left, you have to do both because they're growing, and also you have to compare because sometimes the growth plate have a line. You want to know, is that a fracture?
Wait, what? Hold on, because I
Or
know somebody just said, "What's a growth plate?" What's that, Doctor Moore? What's a growth plate?
oh boy, growth plate is practically when you look at your heel bone, not just the heel bone, the long bone in your body, including the heel bone. It look like a fracture line, but it
Or
is
a broken bone? To break
broken
that down
bone,
more.
yeah, broken bone. But it's like the bone is not meant together yet. That means the child is still growing,
Mhm.
and you expect to see that at a certain age, like for boy up till 15, girl up till 14. If they're 10 years old, you don't see that. That means they stop growing, and that's not good. And you
Exactly.
have to refer them to, it's
Back to the pediatrician.
back nutrition, even neurologist or something
Mhm.
is
Or
not good. So
endocrinology. Yeah.
yeah,
Endocrinology.
and yeah.
Mhm.
So you
Absolutely.
need to see that, and it's one of the most common in the heel bone because of overuse and Achilles tendon and not stretching enough in all sports.
Fully agree. There's a condition we call Sever's disease.
Mm-hmm.
Sever's disease occurs more in boys and girls, but usually it's an inflammation of the growth plate. So the growth plate, you usually see smooth, nice heel bone. On kids, you'll see it looks like almost like a broke the bone, which is a growth plate. And a lot of times, because as she mentioned, the Achilles tendon, the long tendon, the longest, strongest tendon in the back of your heel is pulling. And a lot of times the bones are growing faster than the tendons. And so there's a pull, tug of war that's happening where the bone's pulling, the tendon's pulling, and the kid is miserable because they have inflammation. For me, treatments are anti-inflammatories, over-the-counter Motrin, stretching exercises. I love sending kids to physical therapy. I fully agree with you.
Like
I feel like the parents, it's their kid. You don't want to see them in pain. You may not want to do everything, but definitely the therapist gets them moving and grooving. And again, the inserts, as we talked about, that help the kid have the proper position of the heel and gives them great relief and better flexibility and mobility.
like for me, actually, if the kid having a lot of pain, they hate me for that. And I'll be like, I'm sorry, at least 2 weeks, I'll wrap them up. 2 week, strap the foot,
Mhm.
no activity. And I said, look, do you want to be the next LeBron? You need to take care of your foot.
Right.
Because if you don't take care of your foot, you won't be the next LeBron. And then so they're like, but you could see, I see sometime when the parent or like have no control over the child, that's something else. But they like the child like don't refuse to, and the parent is compromising to the child. And I'm like, don't you understand, this can be serious, it
And
can be a
permanent, cause
problem.
permanent problems in the future.
Exactly. And
Mhm.
Dr. Pennington, so some of the times we get where sometimes it might be the coach who's, pushing the parent.
Yes.
And,
Right. That's
if
what I
this
was going to
child is
say. Right. The
right,
parent needs to be the advocate for the
absolutely.
Mhm.
child to, if they can, to at least meet the coach, find find out what the program is, go to a practice and see, see what they do. And also, there's this whole thing, no pain, no gain kind of thing. You need to be able to tell your child if you're having pain or if there's something, let me know. I'm the adult. I'll step in and handle it.
Yeah,
Absolutely.
and like I tell them to always tell the coach, LeBron James have a personal trainer, my child don't,
You
and that's
love
what
LeBron,
I
okay?
do,
LeBron
right?
has been
Oh,
mentioned like 10
because
times
you
tonight.
have to drill that, because when you tell them that, they're like, it's true. I mean, they have a personal trainer who take care of them 2 time a day, stretching and everything. Those kids, they, I see how they push the kid. They're like professional level, and then they have nothing, and
Without the
that's why.
professional support. Right.
Yeah, and
Exactly.
that's why they get hurt. And I say, if then, yeah, I say, then, You're not gonna have your professional level, and I'm not gonna have my first word ticket from you when I joke.
We have so that to all of our patients or peds, we want our tickets. Okay, we
Yes,
helped you. We
Like
listen.
we knew you when.
We knew you went, and that's what we're gonna do. We knew
yes,
you when you were so high. We sound like the old folks, but we want those tickets.
yep.
I wanted to say thank you. I see Benea Smith. Thank you very much. She says this is very informative. Dr. Linda Susan Cameron. Thank you. South Orange, New Jersey. We appreciate you watching. So we talked about the heel. We talked about the shin. Let's talk about the ankle. So, I think our teenagers are the worst with the ankle problems. And I know you send me a bunch, Dr. Pennington, and I'm just like, okay. So the things that we see, why do you send, why do you send patients to us? Just because of pain? What do you see when those young folks are coming to you for discomfort?
Usually, again, if it's a teenager, by the time they get to me, something happened 2 months ago. They never got it checked out. They never had any x-ray, and it's just not getting better. So those are the ones that I would just send immediately to you. If they happen to come to me sooner, like it just happened, then I would do, put them out of sports, which they do hate because they're like, we got a game this weekend. I'm like, well, this game this weekend is not as important as your whole future career. Rest, ice, no gym, anti-inflammatories, ibuprofen, and then I will reevaluate. And then if it's not getting better, then I would send to you.
Okay. I'll comment, and then Dr. Moore, I'll pass it to you. I say if they're in pain from an ankle, take an x-ray. The x-ray is easy because we're looking at alignment to see if there's anything that's out of alignment that goes, And it may not that be it's a broken bone, because people are like, I didn't break my ankle. You're right. But you have ligaments like elastic bands to support the joint, and that can tear partially, fully, 2 out of 3, 1 out of 4, as many permutations and things that we have to look at. Number 2, to have an evaluation of what that joint should look like. There's certain tests that we look at, like anterior drawers tests, and a bunch of others, to see the functionality of the ankle ligaments. Are they working the way they're supposed to be working? So I would say to the patient, any patient, peds, and their ankle is hurting them, because kids usually don't complain about stuff unless it's something, send them to us immediately, because we're going to be able to A, stabilize that joint, B, reduce the pain, and C, get them back to better function. Dr. Moore, when you have your ankle sprains, what do you do for our teenage patients?
Yeah, everything you guys say. One of the things I tell my patient, I say, look, an ankle sprain can be as bad or worse as a fracture. They're looking at me, why? I'm like, what? I say, number one, you have to really tear before you fracture your ankle or break your bone, the ankle bone. You have to rupture all the, like Dr. Kodai say, all your ligament before. So therefore, you might have sprained it to the point right 1 millisecond away from fracturing. And then later on too, you're gonna have the arthritis, ache and pain. So number one thing you need to do is immobilize it. So you wait
What
two,
does
3
immobilize mean? That's a big
mean
word.
wrapping the foot, holding it together and wrapping it and let it rest, let it heal. Like you say, let the ligament, the tissue heal. Even if they come in limping after 2, 3 weeks, I am doing it for at least 2 weeks. And then I'm not gonna send you to physical therapy right away if you're having a lot of pain, because what they're gonna do, they're gonna yank, pull, and
Cranky,
then
cranky, cranky.
and you're gonna be in more pain and can even cause more problem. So
Exactly.
after you stabilize, if you come back, you're feeling better, or some people, that tearing is not here, the ankle become weak, unstable. I'll put a brace on, and then I'll send you to therapy to give you, when for strengthen the ankle, and then again back to our good old orthotics.
I like physical therapy. If you're in a lot of pain, I'm going to stabilize you.
Mhm.
Anti-inflammatories. I'll even give, if it's a child of a certain age, a steroid injection, but you have to be skeletally mature for that, meaning
Mhm.
that we don't have open growth plates. Um, and yes, a lot of it is, bracing. I might put you non-weight bearing, meaning I might throw you on some crutches if it's really bad, or put you in a walking boot which you see people all around hobbling, because it's going to, that boot protects the ankle from the full range of motion that you would normally have. And obviously, if you're not getting better with those types of things, then we send, adults and children, but as we're speaking about pediatrics, for an MRI. An MRI is going to pick up on all the soft tissue, ligaments, and even cartilaginous things that more children have than anyone else, to make sure we're not missing something, to decide if something further needs to happen, either longer mobilization or if a surgery is needed at that point. So those things are important. Yes, Marnell?
Yeah, one of the thing I have when I have a patient that during the stage now they need surgery, I really have a very hard talk with the parent. And because I'm telling the kid, what is your future? What do you want to do when you grow up? If they really focus on that sport,
Mhm.
or I want to go at professional, I want to go college, I want to go professional NBA or NFL, I said, then let me tell you something. You're gonna need to work hard to strengthen your ankle, because I say if you come in, you already have surgery. I'm sorry to say you're damaged good. That college is gonna think about not taking you, and also that NFL, because you have to strengthen, because they look at that. Oh, I have an ankle surgery. You have an ankle surgery. Then you're gonna be the last person they're gonna take, and you might not have that opportunity. And that's why I tell the parent, that's one of the reasons you need to invest in physical therapy, working and wearing brace. And I tell them, go to the internet, learn how to tape professional athletes. You see how they tape their ankle, their foot. You need to learn how to do that, since you don't have a personal trainers. Wear ankle braces to protect yourself, because once you touch a patient for surgery, again, you already mess up their future. Not you, but the future, the damage good.
So I agree and disagree. I feel that it depends on how good the recovery is. And I feel like I've had friends who've had injuries, and I went to a Division I school, the University of Miami,
Mhm.
and yes, I had to do that. And I think that a lot of high schools have a trainer or somebody who works with the coach, but it's not like it's your personal trainer, as Dr. Moore said. So I believe the trainers are good, but a lot of times they need to know when enough is enough and send them to us, so that we can get that student athlete back to the full function that they need to be at, especially if they're competitive and we're trying to get into schools for the sports. I think that's very important. Um, I feel that with ankles, even let's talk about dancers for a second. Dancers, particularly ballet dancers, endpoint, that
Mhm.
is a major thing. They tend to get chronic ingrown toenails, something called turf toe, where the big toe is chronically hurting them.
That
They
is
develop a lot of arthritis a
on the
lot of
big
times as
toe.
they age.
Mhm.
Football players, tons of arthritis from the trauma, the ankle being pushed in this way, the knees, what have you. Basketball, the Achilles, and their ankles. So a lot of it is trying to be as supple and as flexible and as strong in those ligaments in the foot and ankle as you can, to be able to continue the activity for as long as you can. And I just wanted to say thank you. You see Sharon Carpenter giving us a shout out from Detroit, Michigan. Hi, thank you so much for watching. So I have a couple more questions. Dr. Pennington, we've talked about flat feet, we've talked about pigeon toed, that word. We've talked about ingrown toenails, we've talked about tippy toe walkers, we talked about ankle injuries, we talked about shin splints. Tell me, what else do you see? Because I know there's another thing that we see where I'm like, ooh, and I'm like, these poor parents. Tell me, and I'll tell you what I think it is. Tell me what else you think you see from the
Uh,
pediatrics.
you're trying to get at something, and I don't exactly know what you're trying to get at. Um,
Fungal nails and
oh,
athlete.
oh,
Oh,
I'm sorry.
Girl, I know it's 7:50. I get it. So when do you decide to send them kids when you see an abnormality of the nail and or skin to us?
So I tend to send early just to get treatment early,
Mhm.
because in the past, I've been doing this for a minute, I kind of try to treat on my own, not always as successful. So I'm going to put it in the hands of the people who, know best. Get the treatment early.
Smart. Smart. Dr. Moore, tell us about kids that you see with fungus on their nails and fungus on their skin.
Yes, usually with the most people know the nail, but they not recognize the skin. And I usually say, you see all those peeling in your skin. You put lotion, and they still you could still feel see the peeling. That's a fungus, or at least feet. Is the same thing. And then between the toes, because the whiteness, the smelly, and
It's the
they
smell.
oh
Woo!
yeah,
Our
the smell.
athletes, God help
Oh,
us. I
Yeah.
pray for you, parents.
Sweaty feet.
yes,
Yeah.
sweaty feet, and also
Mhm.
too, and it's because of the sweaty feet, and also putting lotion in between your toes. Most people, I'm like, you cannot. Between your toes supposed to stay dry, dry, and dry. And also, what I notice is people do not wash between your toes. You need to wash between your toes. That's
I'm
what
sorry. I just, as a podiatrist, I just get the heebie-jeebies. So,
That's why you have at least feet. That's why you have smelly feet. Every time you shower, you need to literally soak between your toes and rinse it and then dry between. Do not put any lotion, anything at all on between your toes. That will cause at least feet. But number one, too, is sweaty feet. Sweaty feet. Long time ago, you remember Kodai? I think it's like for Malay. They don't have that. We used to have some a drying agent that help with sweaty feet.
mhm,
I haven't seen it since COVID,
mhm.
and all of them is not on the market. So I tell my patient, go to the store, go buy antiperspirant deodorant, and use it, and that help a lot. If you have a lot of, use it once a day, and then once the dryness stop, use it every other day. So you might use it once a week, or you might not need it at all. That's what I've been using. I don't know if you have an alternative,
I
but
have some things.
oh, please send it to me,
Oh,
because I couldn't find anything for my patient, because
I,
okay.
you
I'm
know,
learning. I never thought that. I'm gonna use that.
if the
Just put the
patient
antiperspirant on the
Mhm,
feet.
exactly, if the patient has sweaty feet, there was a lot of Petty Dry. I think still exists as a powder,
no, the
and now,
powder don't work.
but and there's so many products now over the counter that are now deodorant for whole body. There's been advertisements about them.
Oh,
That's the new thing.
Right.
Yes.
It's a new thing because they're realizing people sweat. So I like that as a first start. If there's an odor to it, I usually add on topical clindamycin because you are having a bacteria that's causing this horrible scent besides
mhm.
hygiene, and that helps with it. So we'll use hand in hand. If the patient has fungus between their toes where it's white, I usually give them a little sample of betadine or iodine, and I tell them to wash between their toes. And I like products like cyclopirox, which is prescribed to use. I think that's one of the great agents. If it's horrible, where I'm like, I might put the patient on an oral antifungal, such as Lamisil, maybe for 2 weeks with everything, which has worked quite well. And for our fungal nails, we've had a show on that, so I won't get into the details of that. But oral medication or topical medication, and even laser,
Or
depending on
both.
how advanced or how mild the fungus is in the nail. So yeah, and you know what? It's funny because we have 6 minutes left. I wanted to say, Dr. Pennington, it's good when pediatricians, when we do a collaboration, the grand collabo, because we know what we know well, and you know what you well. But now, if we put it together, how can this patient fail?
Well, yeah.
Yep.
Do
Yeah.
great. And the last part of the collaboration is you, mom and dad, auntie, cousin, play cousin, grandma, your favorite, whatever,
Yeah.
godmother. We really want you to make sure that, and we thank you for
Right.
bringing your patients. We know that you love your children, and we
Right.
thank you. We try to give you the best care we can, and
Yeah.
it
I always say
you are
that.
the
Oh, I'm
doctor.
sorry. Yeah, I always say, you're with your child 24/7. You know your child. If there's something off, and you take them to the pediatrician, not listening, you need to reiterate and take them back, because, like I said, you know your kid, and you know when something is not right. Don't let them say, "Oh, it's
Okay.
working." Yeah. No.
So, with that being said, I'm going to start with Dr. Pennington. Dr. Pennington, thank you so much. Dr. Demetria Pennington, tell us where we can find you if anyone wants to make an appointment to see you.
So I am at Neighborhood Health. It is located at 1700 Myrtle Avenue in Plainfield, New Jersey.
Thank you. And Neighborhood Health, you can find at Neighborhood Health on Instagram and on Facebook, typing in Neighborhood Health. I know I'm a little bit more social media friendly than she is.
Yes, I'm old school. Sorry.
Oh, that's all right. Old school is cool. Dr. Moore, where can we find you?
Happy Feet Podiatry. I am located at 310 Central Avenue, East Orange, New Jersey. So you could check me at happyfeetpodiatry.com.
And thank you, Sherry Richardson. She enjoyed the show. And thank you, Morgan Love. We appreciate it coming from Texas. We love it. Hot Texas.
Right.
Everything is big and grand. Thank you so much. And you can find me, Dr. Cordai Decoto. I am affectionately known as Dr. D. I am on Instagram, Facebook, LinkedIn at All Things Talks with Dr. D. Talks with Dr. D is the umbrella organization for my pillar of Stepping Forward with Dr. D on blackdoctor.org. Our famous Sisters on the Vineyard, which occurred for its second year on lovely Martha's Vineyard with our keynote speaker, four-time Emmy-winning award winner, Sunny Hostin, and guest, our lovely actor and activist, Malik Yoba. And Talks with Dr. D started with breast cancer, and you can find out more about that, especially as we come upon Breast Cancer Awareness Month. So what will be our topic for next month? Because we're never boring. Next month, we're going to talk about 3D bunionectomies. People are like, a three who? Yes, my darlings. We do 3D bunionectomies. And we are going to have on Treese Medical with the founder of Lapiplasty, one of the founders of it, my friend, Dr. Jody McAleer, and my other friend and sister, who is one of the top surgeons, even though myself and Dr. Moore are quite good at it, Dr. Ebony Vincent Sleet. So we are on the first Wednesday of every month, 7 p.m. live. If your friends have missed this great show, tell them to log on at Talks with Dr. D. You can find it on my YouTube page that we usually post within the week. You can also go to Facebook and press on Talks with Dr. D or blackdoctor.org, which host is the umbrella for all of our programming. I want to thank everyone who tuned in from everywhere, from East Coast to West Coast, from North to South, and the Caribbean. We're looking forward to some flying fish from Barbados. Thank you so much. I thank my guests, again, Dr. Demetria Pennington, board-certified pediatrician and assistant CMO of Neighborhood Health Center, and Dr. Marnell Moore, CEO and board-certified podiatrist for Happy Feet. How can you not be happy if you have a practice of Happy Feet? How could you not have your pediatric patients excited about that? And how could you not have your peds patients, Dr. Pennington, being happy when you see them running down the hallway because of
Yes, 100% agree.
So again, thank you so much. Thank you to everybody. We love that you tune in. And with that, we say walk strong, and we'll see you next month. Bye-bye.
Right. Thank you.
Bye.